Let's move on to our next panel discussion of the day. When people hear about mental illness, they often have several different ideas about what it means. Mental illnesses are often stigmatized, resulting in those living with one being judged, discriminated against, and isolated even from society and those who care for them. Take a look at the most common myths surrounding mental health care and learn from these experts to better understand the concept. They're going to kind of help us navigate through those too. To act as a moderator of this, we have Isiah Coles, Chief Operating Officer and Integrator of Outreach Recovery. Please take the stage and introduce us to our panel of experts. Come on up. Round of applause.
Well, hello, Healthcare 2.0. This is actually my second conference, and I've enjoyed my experience every time that I've attended this organization's conference. My name is Isiah Coles. I am the Chief Operating Officer at Outreach Recovery. We are located in 6 states, 23 clinics, encompassing primary care, all types of behavioral health, and counseling services. I will be the moderator today for mental health fact or fiction, and I will allow my panel to introduce themselves.
Hi, I'm Dr. Tanisha Ranger. I'm a clinical psychologist practicing here in Las Vegas. My main focus tends to be working with Black people in the diaspora, so not just African American, but Black people from everywhere, and working with them on maintaining mental health in a world that is determined for you not to have that.
Hi, my name is Jesse Lyon. I'm the Chief Dream Scientist at DreamApp. We're a mental health platform that interprets people's dreams and then uses that as a diagnostic and therapeutic tool to help them with their mental health. My personal background is as a licensed mental health counselor in Central Florida, Orlando, with a couple offices there. And during COVID, things were getting a little hairy, scary. So I turned to social media and started trying to help people as much as I can to outreach in that way. And I really landed into the dream field and helping people understand and really look into their dreams to understand what they meant. And so that quickly grew. And so I currently have a following of 1.6 million on TikTok and just creating a community around destigmatizing and accepting, understanding mental health there.
Thanks. My name is Azmat Husain. I'm an emergency medicine physician by training. I'm the Chief Medical Officer and co-founder of Personic Healthcare. We're a multi-specialty healthcare organization located in the Northeast, headquartered in Northern Virginia. We also, similarly to Isiah's organization, provide in outpatient operations, advanced wound care, but heavily also in behavioral health. We operate several mental health treatment facilities, which include advanced modalities such as transcranial magnetic stimulation, TMS, Spravato, and other counseling therapies. So excited to be here.
Hi, everybody. I'm Dr. Benjamin Keys. I am a professor and the director of the Center for Trauma Studies at Divine Mercy University, also in Northern Virginia. At the center, we operate from a immersion model where we train people in aspects of both first response trauma and long-term trauma. And then we immerse the students into a culture, usually overseas, but we immerse them into a culture where they get to work with their skills and work alongside of social workers and counselors from these other countries, working with their clients actually on very serious, deep, traumatic issues.
Okay, thank you guys. Well, when we say mental health, behavioral health, there are so many misconceptions, misunderstandings, labeling that we see. As a somatic provider for 25 years, when somebody would tear an ACL and we would do the surgery and we'd do the rehab, it was very, very objective. We had protocols that we followed. You can measure, an angle, how much the knee can bend or how much extension you can get. And when it comes to mental health, it's a little different. The way we measure success is different. The way we treat a ACL patient compared to somebody with depression. If somebody tears an ACL on a ski slope, oh man, you tore your knee on the ski slope. How courageous of you. But if somebody says, I have depression, from either from trauma or an experience they may have, the sense of understanding and recognition automatically changes. So what we're going to do today is we're going to go down our panel, and they're going to share with you some of the myths that they find in dealing and working with these population of patients.
Should I start?
Yeah.
Okay, I'll start. So I had a little bit of trouble narrowing it down because when it comes to Black mental health, there are a lot of myths that fly around and get in the way of Black people actually getting the help that they need. So I will narrow it all down to one big myth, which is the myth of Black strength. Assuming that, Black people are strong and they're able to endure and they can deal with all kinds of things and thus don't need help or don't want help, or all of these things that are both prevalent within the Black community, but also outside of the Black community, leading clinicians and practitioners to not take Black pain seriously and not to treat it with the same urgency and curiosity even as they would treat any other person. And so that comes up in a lot of different ways. It comes up in Black people feeling like, if I admit that I need help, if I admit that I want to go see someone for mental health treatment, then that's a sign of weakness, and I can't let anybody know. There's the outside of people who steadfastly believe that Black people don't want therapy. They're not interested. They don't think that's going to work. They're going to go to church, they're going to pray, and they're not interested in mental health treatment, which could not be further from the truth. The fact of the matter is it's hard for Black people to find culturally competent mental health treatment. And given what has happened in this country since its inception, it is not out of the question for a Black person to not necessarily trust the medical field or the psychiatric field, given how, as a group, we have been victimized by both. And so that is always a barrier to break through for myself as a clinician and myself just as a person. I had to work on that myself as I was coming up in my profession. So that myth of that strength that doesn't need any help, that can trudge through, that is built for struggle, is nonsense, and we have to get rid of that.
So I'm curious, other folks on the panel, what has been your experience in some of the myths you may have seen regarding, racial disparities in mental health, racial outcomes, or the perception that you may have when you're dealing with, folks from, other minorities that in your patient population?
Sure, I'd like to chime in on that. Previous to joining Personic, I was the chairman of the emergency medicine at Howard University in DC, and also served as the CEO at Hahnemann University in St. Christopher, all urban setting environments. And I think one major myth that we have about whether it's the urban community, whether it's the Black community or other minority communities, is that they lack the interest in access in getting care, and that they're looking for the most. They just flood the emergency departments, or they're not looking. And I think that myth, what we don't realize is their actual access to care is so limited in what we're actually providing them and avenues for outlet. And we get upset in the public health settings in regards to the urban environment, emergency departments being overrun. Oh, they're not accessing the FQHC, but we don't realize that the FQHC is located in the suburbs or so far outside the common modes of transportation for them to access. Or there's not bilingual providers sitting in our FQHCs or other access points that we have. So I think that I've seen is a major myth where we have suburban expectations for an urban community at many times, and it completely is, we're missing the boat on how to actually provide care to these communities.
I know for me, coming up the field, I ended up working for a number of state agencies, including the Department of Corrections. And it's not just in healthcare, because it sort of swings its way into the pipeline that leads from prison to the community and back again. It has to do with access, I think, to support and help, and it's not just a single prong kind of issue, because it has multiple prongs.
Yeah, I would agree with that. I think it's not only just the racial sometimes disparity, but also socioeconomic. Very much socioeconomic. And that's why, things like SAMHSA are starting to expand telemedicine for OTPs, for buprenorphine out into rural areas, because there's not enough providers. So, okay, thanks, guys.
I might jump in there too. I think one of the things that we experience a lot in my personal practice is with trauma. Trauma has to be so understood inside of context, and especially cultural context, because you can't just assume that one thing that traumatizes one individual is going to have the same reaction and effect on another individual from a different community. And so one of the things that we really try and do is make sure that when we're talking with people and users about their dreams and about their mental health experience, is that it's contextualized for them, that we're understanding the way that they interact with the world, their family, and their obstacles, because you can't just apply the same type of routine to everybody. It has to be contextual.
And part of what happens is that Black people are not often included in studies, but then you use those studies to generalize amongst them as if, well, if it works for these people, it'll definitely work for you. But when it doesn't work for you, it's because you're non-compliant.
Right.
And
they blame that.
Right. And so there just gets into a cycle of victim blaming that doesn't leave anybody getting the care that they need.
Very good. So Jesse, why don't you share with us one of your myths that you come across?
Sure. Oh my gosh. I feel like dreams, when their relationship to mental health, get myths on both sides of the spectrum. So being prominent on social media, I get a lot of feedback. Some of that is very encouraging, and some of that is very discouraging. And there's no shortage of people willing to share that discouraging comment. I think the two that I get the most, right, are dreams are totally meaningless. They don't mean anything. They're just nonsense. They're kind of the throw up of your mind and your emotions. And then on the other side, I get some people who are very into dreams, thinking that we can connect with other people, we can transcend to an astral plane and metaphysical kind of expressions. Both kind of miss the mark. When it comes to dreams being meaningless, we know that that's not true. We know that the brain, when it's dreaming, it's accomplishing two processes. It's encoding that information that you've experienced through the day and giving meaning. So creating new neural networks and deepening existing neural networks. And so the process of dreaming is the experience of that happening in your brain. So it's very meaningful, and we can understand and even predict a lot of diagnoses and a lot of things that are happening inside a person's mental health based on looking into their dreams and really taking that into consideration. But then on the other side, there's really no scientific research or evidence to say that, you're transcending planes or you're dream hopping into someone else's brain while they're sleeping. Maybe we'll get more into that research, but I think it's really important not to make some claims that are outlandish, but to really stick with, okay, how can I make this impactful for this patient today? How can I make this really impactful for their life and improve their mental health? That's got to be the focus.
So Jesse, tell us, when it comes to obviously gathering data and using the information that you're getting from the dream, how does the app and the technology you're using come into play with the dream data that you're getting?
Yeah, it's huge, and that's one of the things I'm so proud of with DreamApp and the company is we really started on the commercial side. And so we really focused on making an application and a platform that was enticing to users. And so we've got just an incredible base of users. And to this point, we're currently the largest collection of dream data in the world with 2.5 million entries. And so we use a combination of artificial intelligence and dream experts to comb through that data. And we're looking for indicators of what's going on with their mental health. And we can filter that data based on geographic location, sex, relationship status, cultural influences. And so we can actually get some really good information about how this population is interacting with their mental health, what the implications are, and how we can help them individually. And so it's just been a wonderful opportunity because of this vast amount of data that we've collected.
Great. So Dr. Husain, myths that you come across.
I'd say it's really hard to follow dreams, right? So, that's pretty cool stuff, really interesting things that everybody here on the panel, everybody here and the conference is doing. So it's been really interesting stuff. So, one of the myths that I think, although I think the people in this room would probably all recognize, but I think as a physician, it's important to say that in mental health, I think a large myth is that our standard pharmacological therapies are the mainstay of mental health treatment. And I think that's something that here goes without saying, but I think it's important to reemphasize. And I think one thing that's showing a lot of promise, and I think we've all alluded to, especially in the session before this and the various modalities, is this concept of neuroplasticity. And it's growing quite a bit. There's been a lot of research on this and a growing understanding of how our brains are such dynamic, ever-changing objects, where multiple different inputs coming into our brains can regulate not just the chemical aspects that were talked about earlier with the serotonin, the dopamine, the norepinephrine, but even our synaptic impulses that are going between our axons and dendrites. And there have been so many studies on modalities such as the ones we offer, TMS, transcranial magnetic stimulation, working on the neuroplasticity and enabling a positive changes in the actual physical, chemical, neurologic makeup of our brain to positively impact behavioral health. Therapies such as psychedelics and psilocybin, working on the same concept of significantly expediting and advancing the positive changes to the neuroplastic environment that is involved in behavioral health and mental health challenges. So I think one of the things that provides me a lot of hope and optimism about the future of mental health treatment is that we are going to start to, and have already started to expand the what's in our tool belt to offer to patients. We're monitoring their dreams. Now we're having a lot more emphasis on culturally competent care. And I think all this goes to recognize the vast degree of inputs that our brains take and how that customized treatment regimen can have significant impact. The last thing I'll just say on this introductory aspect of that is that I think really recognizing that there are significant treatment successes that we're having. Johns Hopkins is the one that really kind of created all the noise about psilocybin and psychedelics when they released that up to 70% of their patients 1 year out went from severe depression to less than mild depression on depression severity scale. Right? That's 12 months out. Now again, I'm not here kind of to promote one therapy or another, but I think my point is that similarly, whether it's TMS, psilocybin, all the various new therapies that are coming out, we're seeing some really, really impressive remission rates for depression and anxiety when we never talked about remission before. We talked about managing it as a chronic illness. So really exciting future, and I think these kind of forums where we're talking about innovative models of therapy and treatment are going to be more and more mainstream, so to speak, moving forward.
Well, I know in our practice, older, phobias about recreational drugs like psilocybin, cannabis, now are starting to change. We actually are finding that there are actually medicinal uses for these things, and so we're going to have to break the stigma. I know within our practice, in our states, we have D.C., Maryland, New Jersey, New York. That are all we have cannabis states that are recreational and medicinal for use, and we are constantly battling our patients who want to use street cannabis compared to medicinal cannabis, and there's always a debate there. Mm-hmm. Which one do we want to use? Would you rather have a fentanyl-laced marijuana that you get off the street, or would you rather have it from a dispensary? That's the debate, and we're going to have the same debate with psilocybin as well,
Yeah, one thing I just want to kind of add to that is I think that a lot of the onus of change that's coming forward is really on the providers, the organizations, those delivering the care to really embark on aggressive education campaigns, because that I don't think we do enough of, right? I think we are quite, I don't want to speak for all of us, but I think generally can be quite hesitant and tepid when introducing the concepts of these new therapies to our patients. We're concerned about how we'll get labeled. We're concerned about will they, buy into this. And I think reclaiming or reorienting ourselves to really be educators to our patients, to our colleagues, to our communities is really going to accelerate this transition, because I think we all agree that what we have been doing may have worked in the past, may not have, but it's really not necessarily working right now.
Man, and on that, like being kind of in that public space where you receive that criticism, I've seen it really damage a lot of people's ego and moving forward. But I embrace it. There's people who are going to be really slow to adopt new modalities, and I think that there's some wisdom in that. I think even seeing the advent and the growth of mental health development, I mean that's a relatively newer field because we were dealing with things that were very literal. How do I set my leg? How do I fix this disease? And so that hesitation, I don't fight against it. I think we do need to make sure that the tools and the modalities that we're using are very effective and that they're proven. And so there's some wisdom to that. And then there's also always going to be those people who are really pushing the boundaries and maybe even claiming some things that aren't totally verified yet, but okay, they're on the right track. And I appreciate them moving that conversation forward.
I think that's part of the issue, though, is what is the data showing? And sometimes you get a mixed showing. And I think we have to be careful as we go forward. There are a lot of new things that come up in mental health. And I know I take a sort of a wait and see approach of, where's the data going to be? And if I'm starting to see positive data, then do I need to have a paradigm shift myself in being able to sort of take it on, particularly in the area of trauma, because we're constantly getting new data that sort of flips the coin a little bit and changes the way we look at various things in trauma.
I think the struggle with getting the data is that, as in the field of psychology, a lot of our journals don't publish articles where there is no difference. There's a bias towards change, there's a bias towards difference, but I think understanding that this is not different from that is as important as understanding that this is different from that. And so the data is always skewed. So you never can really know, because all of the studies where nothing happened, everything came out the same, don't usually get into the journals.
And that was exciting.
Yeah, they don't have the pop.
Dr. Keys, what about you? What kind of myths do you see in your practice?
Oh boy. Most of the work that I do has been, actually for almost my entire career, has been in the area of trauma. And trauma happens along a continuum of diagnoses, but it also happens in the field. It happens with disasters, it happens with war, it happens with situations with refugees, human trafficking. There are all kinds of social ills that set up trauma, not to mention the more mundane of domestic violence and divorce and death. And one of the areas that I have worked pretty extensively in the area of dissociative disorders, particularly what we now call dissociative identity disorder, formerly multiple personality disorder. And one of the myths was, well, if you see this, you'll see it once, maybe, in your entire career. And it's so rare that it's basically non-existent. And that's just a lie. We have established in 62 countries about 1% of the entire population as being dissociative identity disorder. And And it's interesting because they've done various studies that indicate just how real it is. The one that really stands out to me is, I think it was Anna Vanderhart did this with colleagues. And what they did was they were measuring the points of cognition. In other words, the point in the brain where the cognition recognizes a stimulus. And they found that the point in the brain was different for each alter that was tested. And this was about 10, 15 years ago, that just really established the reality of this. And part of the reason is that it wasn't until 1989, 2 books were written on diagnosis and treatment of dissociative disorders. They were the first 2. One was by Frank Putnam, who was working with NIMH, and the other was Colin Ross, who has the Ross Institute and was in Richardson, Texas. It's now in Austin. But those 2 books really established what we were looking for. Now, there is a cultural model that says, you know, of course you find it. It's in your culture, it's in your books, it's in your movies. So we took a team to China some years ago, and this was 96 to about 06. And we did a series of experimentations looking at differential diagnosis with schizophrenia. And that's because they share the same symptoms, or some of the same symptoms of the positive things, the things that are added. They're called Schneiderian first-rank symptoms. And we trained a group of psychiatrists in the Shanghai Mental Health Hospital in Shanghai on how to look for, how to diagnose. We had an Integrator reliability of 93.4, I think was what it finally came out. Very high Integrator reliability. And it showed that that dissociation existed there in trauma. Now, what's important about that is it wasn't in their books, it wasn't in their movies, they didn't diagnose it, it was not even talked about because nobody knew about it. And yet we found it to be at the same level as every other country in the world.
Man, I totally agree. I think when it comes to trauma in particular, it's almost even bigger than a myth, because I find that when I work with other therapists and when I talk with other practitioners, they really struggle to have a solid definition of what trauma is. And so even kind of bigger than just a single myth, there's kind of this inability to really accurately define trauma. And so that's something that I've spent a lot of my career trying to make sure, hey, what is trauma? Because if the data shows that we are flip-flopping what trauma is and what it's not, that means our definition's incorrect. And so we need to have a definition that's culturally mindful and that follows the data. And so I think, like, really when we get down to it, it's a lot about identity. And in an experience, a physical, real-world experience where an identity is ripped away from somebody without consent, in that moment is trauma. Now, what that identity is for each person is going to be unique. And I think that's why we see kind of these differences in cultural variabilities. But really being able to accurately define trauma has to be something that we really strive for, and something we keep pushing towards.
And the process that I'm talking here is mostly around sexual trauma prior to the age of 8.
Sure, yeah. When identity formation is so important, absolutely, absolutely.
I'm going to put my layman hat on a little bit, non-mental health. And there's so much fascination in the movies about multiple personality disorders. That's what most people know. Most people don't know what DID is, you know. So can you tell a little bit of the audience, is there certain stigmas about people with multiple or DID? Are they more violent? Are they more, is there a certain pattern of behavior? Because the movies seem to fascinate and make folks with DID to be very violent, very, characteristic in the sense where folks like elected officials that we have in the recent elections have been diagnosed. So can you tell us a little bit about the stigmas you see with folks with DID?
You know, it's actually a shame that it is a diagnosable disorder, because it's really more of a self-protective mechanism. It's a self-defense mechanism. It's a way of compartmentalizing yourself as a child. It's a wonderful mechanism to protect that core sense of self. And we used to think, and that's why the name changed, we used to think that they were separate personalities growing up alongside of each other, but they're not. It's a single personality that's fragmented, hence the name change. And it just floors me that, you know, and to answer your question, you wouldn't know, in most cases, you would not know that a person is DID unless they told you. Typically, they hide it, very often ashamed of it. They feel very different, they feel broken, and they blame themselves for all of it when this was perpetrated upon them. So what do we look for? We look for how people carry themselves. How they speak. Are they looking down all the time? Are they withdrawn? Are they missing information? Do they hear voices in their head commenting on what they're doing? All kinds of symptoms around it that it is noticeable, and that we as clinicians, of course, can identify to be able to know that that's what's going on.
So, Dr. Husain, you mentioned you were in a multidisciplinary practice where we've talked about that a little bit before, the mind and the body. What are some of the myths that you see when people try to disconnect those two? Really, they really are the same.
Sure, yeah, absolutely. And I think that itself is the myth itself, that they are disparate and that they are unrelated. And I think what I see as a major challenge is that even from a public health standpoint, even from the payer standpoint, reimbursement models, we treat them that way, right? You have distinct, in many states, you have carve-out states, you have distinct behavioral health payers and distinct physical health payers, right? And I think it's starting from the top, right? That we have bifurcated, and I understand the concept of wanting to ensure that mental health and behavioral health doesn't get lost within the greater sphere of medicine, but we've got to find a better way to really promote multidisciplinary care, because right now, unless you're, not taking insurance and not or charging patients cash, there's really no way to, not a very effective way to combine it in a very pragmatic way. And I think that's something that, for example, those patients who, mental health providers who provide, advanced therapies or advanced medications, whether it's Spravato or ketamine derivatives or different things, they have to bill the mental health payers for the observation,
that's right.
And they got to find a way to bill the physical health payers for the medication, but they'll both deny each other, right? So it's kind of like,
yes. I feel that pain every day.
And so I think, again, going back to what I think as organizations, as providers, as those who are in the sphere, we've got to do a better job of speaking up about this. And I think whether it's, again, to our colleagues, our patients, to the public health powers to be, we've got to start to move the needle, because right now, all the innovative models and all the great things that we're talking about are wonderful and they're phenomenal, but unfortunately, as we were talking about amongst ourselves, you're really left treating and forced to really only focus on those who can pay out of pocket, as opposed to taking the vast majority of individuals impacted.
And then even with parity, having mental health parity with our medical insurance, it's just a name alone. It's still incredibly difficult for people to find care, let alone multidisciplinary care. Like, just give me one discipline and you can't get it. The insurance companies provide these lists that are out of date. They have clinicians who are not on the panel. They have people who have passed away. And it gets really demoralizing for a person who can't just pay out of pocket to even find someone to start this process with. And then we come to the part where it's really the innovative things are really only available for people who have a lot of money.
Yeah.
You're talking also, you actually started this in talking about access. And I gave some testimony to the California legislature at one point because they were looking at changing the law structure around treating children, and did. In other words, if a child was going into a center, it could not be any longer than 6 months, and they had to be returned to their families as quickly as possible. Well, that's good if unless you're working with, say, a family that's been involved in human trafficking, and the family's the last place you want to send them, and they need long-term care, not short-term care, but they don't have any provision for that.
There's nothing available. Yeah, that's especially a problem here in Vegas. There are not a lot of people who treat children for mental health, and it shows because juvenile facilities they're always really prevalent, but actual treatment facilities are harder to come by.
And then just expanding on that for a second, that how damaging the situation is right now with the lack of outpatient pediatric mental health services. That there was a recent study that came out that pointed to essentially what happens is when a child has because of the paucity of outpatient resources, end up in emergency departments quite often. Well, they end up in emergency departments, and then they're boarding there for 3 to 4 days because the inpatient facilities are lacking. And a recent study came out that children or adolescents who end up in emergency department or get hospitalized for mental health services end up having a 70% higher rate of suicide. 70% because they ended up in one facility versus having appropriate outpatient resources potentially could have mitigated that significantly. So when we talk about crisis, when we talk about the next pandemic, the epidemic, we're living it right now.
Yeah. And outpatient resources also includes, prior to having to see a clinician, support for the family, support in schools is really helpful.
Well, and I think that's really where we've seen such an improvement, because when you pay attention to the precursor indicators like dreams and other things about your mental health, you can kind of intervene on some things before they get to the point where, well, we're really kind of against a wall now. And so by being able to look into these things, and I think community and relationships has a huge part to do. You know, when we're looking at the people who come and use our service, it's always relationships are the first step into that. I had a dream about my partner cheating on me. I had a dream about my ex. I had a dream about that crush that I like, that I saw. And so they're like, I want to know what this means. And so what we do is when we dig into that, we find like, there's a relationship component. There's a difficulty with the relationship I have with myself. And I think there's a lot to be said about identity and DID there. But even more, because of that difficulty with that relationship with myself, there's a larger difficulty with me connecting with the community and those people around me. And so you can see that breakdown kind of happening in those precursor events kind of makes this these symptoms become really exacerbated and turn into these large problems that we see.
But doesn't that presume, though, that you're in a city that has resources?
Or in a city at all, because rural people have startlingly few resources.
Correct.
Well, that's what I think what we're talking about is like the community has such an impact. Your relationships have such an impact on your mental health. So if it's rural, that's a whole separate set of problems and obstacles. If it's in a city, in a community where things are so busy, it's difficult to even find places to have friends and create relationships in a whole different way as opposed to rural, that creates its own set of problems and difficulties. And so being able to recognize those things and intervene there, I think that's a huge myth, is that these things are huge. If we start back with the relationship, catch them there, that's awesome.
Well, one of the things we're working in Maryland, I'm on the subcommittee for behavioral health for the state of Maryland, and we are desperately trying to bring pediatric and adult family health and family medicine providers into the behavioral health space. We're actually giving grants away to get them more engaged. Think about, when you take your child in to see the pediatrician, they check weight, blood pressure, eyes, full review of systems. How often do they do a mental health evaluation?
Yeah, they're trying to do that a little bit more in the VA.
Yeah.
It's not working that great, but I applaud the effort where they're having the primary care mental health integration, where there is a person who is like the liaison between the two. But when we go back to the myth that Dr. Singh was talking about, which is about medication, I think that as a whole, we do not emphasize enough how much relationships and connection
Yes,
are related to mental wellness, and that therefore people are like, oh yeah, no, I don't have any friends and I hate everybody at work and I don't talk to my family, but I'm pretty sure this pill is going to help my depression. And it's like, I doubt that.
And then, you know, going off of that, I think what we fundamentally also, you know, I think it's great, in speaking as a physician, gone through medical school, we really need to really look at our educational curriculum for medical providers in general. Right?
Yeah.
Where I think it's so, you know, it's great to talk about involving primary care docs, emergency medicine physicians, and everything else. But I really look back to myself and, you know, am I armed with the proper tools?
Right. Yeah.
The tools I have is SSRIs, right?
That's
That's how I'm ingrained, or Haldol, or you know, something really acute in the acute care setting. And I think, you know, the education of our colleagues, of our providers, going back to really basic levels of medical education across the spectrum of providers, I think is really, really important.
But it's always been basically set up from the very beginning that medication needs to be coupled with counseling.
Sure.
So that you get both, one, to monitor, of course, the effect of the medication, but more importantly, to integrate the concepts along with the use of the medication so that the client is on a trajectory of getting well.
Yeah, but the commercials are for the drugs.
Honestly, that's
You're
the
supposed
deal.
to ask your doctor if this medication
No,
is right for you.
That's
Not
what they
if-
say.
Not if therapy and improved relationships are right for you. No, just the pills.
Very correct. And at the end of the day, I mean, I just to put my kind of disclaimer on this, I think what you alluded to is absolutely correct, that we've just tipped the scales way too far on one end of that spectrum, right? And I think you know, medications absolutely are an important part of mental health treatment. I'm not in any way advocating to do away with that. It's just our over reliance on these is, I think, is damaging.
Yeah.
And what we've got coming up, I mean, toward the future, is a lot of technique and interventions that have nothing to do with either. You know, from EMDR to brain spotting to virtual reality techniques to the
TMS,
tapping.
the magnetic imaging. We've got a lot of things that don't really involve a lot either way.
So I guess we'll open it up to the audience for questions.
I was going to say, no
They're
questions? It
coming.
makes it
Yeah,
easy
they're
for us.
coming.
So.
They're going to get us.
Uh-oh.
I think we can hear you.
Is the mic on?
It's not. Someone's coming. She's coming.
Oh, yeah. I think she's coming. Yep.
Hello?
Yep.
There
Yep.
we
we
go.
hear you.
Got it.
Thanks. Hey everyone, how are you guys doing?
How are you?
Thank you for coming up and talking about mental health. It's very important. I just wanted to know from any of you guys, do you guys actually do like any mental health aid training? In my area in Washington, D.C., that's where I work now. And I've been in that area for a long time. I actually grew up in that area. And I think that has been the key to some of our success and just helping our community and gathering our community and making sure that our community is involved by giving that mental health aid training. And those are just for people that are lay people. It could be really anybody that goes to those classes. So I was just wondering, what's your feedback on that? And do you guys offer that to your communities?
Well, within our facility, you know, we have a multi-tiered of specialties. You know, we have our psychiatrists, we have our MDs, we have our, you know, obviously our clinical staff, administrators. We enroll all of our non-therapy staff in mental health first aid through NAMI at Montgomery County. Yep. And so Montgomery County, Maryland has done a really good job with mental health first aid. And it's really good for the parents. It's really good. I mean, anybody who's really not a mental health specialist, it is a really good tool. I am not sure how far it's expanded across the country. We're in 6 states. Really, Montgomery County is probably the foothill of the mental health first aid training. And I think it really could expand further, but I'm just not sure.
We do have something like that here in Las Vegas also that trains people who are not mental health professionals to be of assistance in the case of like a national emergency or a disaster or anything like that. And then there are people who train to like go with the police to a scene and actually sit with a person and try to help them as whatever's going on is going on around them.
I'm also the executive director of Green Cross Academy for Traumatology, and they have certification courses actually for those that are non-professional in the area of compassion fatigue, in the area of assisting as a field traumatology specialist. I mean, anybody who can take basic training that comes under the heading of psychological first aid can offer assistance and help in a traumatic situation. And those are the skills that we also teach paraprofessionals, police, firefighters, EMTs, teachers, pastors of churches, chaplains. So I think it's just a matter of really looking for it. Most health departments have what's called CERT teams. This is the citizens' response teams for disaster situations. So is it coming across the community? Yeah, it's starting. It's building. Could it be better? Absolutely.
I think just one step above that, also that I've seen to be quite successful, are what are called, every state uses different terminologies as well, and that's part of different acronyms. But what we recognize across is that there are not enough providers for the amount of caseload and patients that are out there. And so, do we try to entice more psychologists, LCSWs, physicians, or do we try to create new classifications, easier classifications of those that can at least be involved in screening? So in the state of Pennsylvania, we have what are called BHCs, behavioral health consultants, which I found to be incredibly promising, where they could be trained a much lower intensity of education and easier to be able to get, but very effective in being able to screen a large group of individuals by deploying a much more robust team of BHCs.
Yeah.
Man, and I would say that that's been the huge push of our company is getting this mental health content and getting rid of that myth saying that you have to have a professional. Of course, you should consult a professional and do that, but some of these things can start with yourself. And so putting that in the hand of the patient, in the hand of the user to start that relationship with themselves and say, oh, wow, there are these indicators that are going on. I can see this going on in my life. And then talking with someone who's available 24/7 to be able to say, hey, what steps can you take now that you can do on your own to start to heal these things? Because it's totally within your grasp. And I think a lot of that comes from people having this antagonistic relationship with themselves. And so when we break down that stigma and say, hey, your mind is not your enemy. It's not against you. It's just misunderstood. Here's the tools to help yourself. I think that's a myth we have to overcome.
Sorry.
Let's go to the next
there's something that happened during the pandemic that I think was just huge. And that's the walls came down between the states, and we got to talk to or counsel people in whatever state they were calling from. And the walls went up almost immediately when things opened up again. There's what's going on right now in mental health is a counselor compact between states. And this is the first giant step toward parity across the board and being able to counsel in other states as long as by recognizing each other's licensing.
Yeah, great panel. There's a common theme throughout all of these panels is that what people need, is community, right? Connection, and to unload their trauma, right? And I feel like hearing a lot of panelists, they feel like they're bullied by mainstream science, right? That what you're doing isn't quantitative, qualitative enough. Well, as someone who comes from that, side of things, I would encourage you to keep doing it because mainstream science is biased. Every organization that proves something is biased.
Yep.
And they're slow to change. And that's been true in the history of science. So what you're doing, what the fitness people are doing, believe it or not, you guys are cutting edge.
Thank you. One more question. We got 1 minute. Okay.
I'd like to reiterate what David said. Great panel. Really appreciate getting to see you guys here today. My question, the title was around myths. And I think we've seen a lot of really good information come out of social media, a lot of high-profile people coming out about their mental illness, about things like that. And I think that's really helped raise awareness and raise acceptance of mental illness. But how do you think it's affect myths around mental illness? Have we created new myths? Have we been able to dispel the old myths? How has social media kind of helped with this?
I'll jump in on that one because that's kind of my whole platform. All the social media stuff.
We all look right at you, so.
Yeah, that's fine. That's fine. No, I'm all about it. So with any quoting comic books here, but with great power comes great responsibility, right? So it's like social media is just a fantastic tool to connect human beings with one another. But you connect human beings, you're connecting all of the human beings. You're connecting the wonderful resources and the helpful people, and the people who just kind of want to do some nasty things online. So there's a real power in being able to start, I think, a conversation. And so looking to social media as the answer and the place to get your diagnosis for yourself or to get your treatment for yourself, we need to create a better conversation around that and using applications and platforms, doctors who can give that advice. But what I really value social media for is finding that community, finding that connection, and then being able to increase the conversation and the dialogue around these things so that way people can start to help themselves.
Yeah. There are things we talk about on mental health with our social media that never would have been spoken aloud before. And so I do think that celebrities coming forward helps to break some myths. It does kind of solidify some other ones, which are that's rich people business. That's not something that either can affect me, or if it does affect me, I can't get help because I don't have that kind of money. And so one of the things that I do on social media is let people know about all the ways that you can get some discounted rates, some free therapy, some help and support that doesn't cost an arm and a leg. But I think that, social media and celebrities coming forward really has actually been very helpful.
That's a great question. Thank you.
Because the communication has got to include the professionals as well as part of that community.
Yeah. Okay.